Hello, Dr. Alika Lafontaine, Dr. Lisa Calder, and Dr. Kamea Lafontaine. Are you here? I'm just looking for you, Kamea. There you are. Good. Okay, let's begin then. It is my absolute pleasure and honor to introduce you to our next panel. Dr. Alika Lafontaine and Dr. Kamea Lafontaine answered the call when we put the call out and said, can we have a discussion and a conference around racism in healthcare? And I know you are a busy man, both of you, and but you both stepped up, and so we are so pleased that you're here, and we are so honored as Friendship Centers to be working with you in this important piece of work that you have done. And Dr. Lisa Calder, thank you for joining us today and committing to be a anti-racism ally and a social justice ally to us as Indigenous people. I will ask you as you begin your presentation to introduce yourselves. Thank you.
Sure. Thank you so much, Leslie, for inviting us to be a part of this event. I've learned from all the speakers who've presented so far. Thank you for being so open and sharing, also to Elder Jerry and those other community members that have been presented. You know, your words really ground what this is all about. We can have a lot of tools and approaches on how to solve problems, but at the end of the day, what we're really talking about is people and stories. And if we can't get back to that at the end of all of this, then I think we've really missed the mark. I'm here to talk about CSpace Networks. It's a project that we partnered with the BC Friendship Centers to implement a few months ago. I'll explain a bit about what the network does, but first I want to give a little bit of an introduction. This is me on the left side, and then my brother Kamea, and in the middle, that's actually my mom. So our ancestries, Métis, were from southern Saskatchewan. We can trace our ancestry through First Nations that are both Cree and Saulteaux, and my mom's Pacific Islander. And there's a story that I'll share real quickly, that when we were all young, she sat us all down in a circle, and there were 5 of us kids. I'm the middle child, my younger brother, then my 2 older brothers and my sister. And she looked around and she said, how are you going to help our family? How are you going to protect us in case something happens to us? And it was at that moment that it started to crystallize that, you know, a journey into medicine could or should be something that I think about. My brother Kamea is a dentist, and since moving out of dentistry has gone into technology and programming and blockchain. Me, myself, I've gone heavily into anesthesia practice, which is the area that I work in, but also national politics. I'll be the incoming president-elect of the Canadian Medical Association, and will speak in behalf of our physicians across the country as part of that presidency starting in the fall of this year. And I think underscoring my mom's ask really came down to the question, if something happens to me, who's going to help me? And over time, I've realized that that question is really, really important. And when we talk about reporting and, addressing some of the issues that have been brought up from different perspectives, the question that I always come back to is, who's going to help me if I get into trouble? And I think as we go through our presentation today, we're going to move away from what needs to be done, because we've already been told that. We've been told that by community. We've been told that by, healthcare providers. We've been told that by scholars that have talked today. The question for us is, how do we create an environment where we can actually take those things that we know we need to do and make sure that they can actually be done? So as has been explained multiple times, it's really risky to report healthcare harm. You have retaliation from your healthcare provider. There's hostility from the healthcare system if you do submit a complaint or concern. Often you can relive the harm without a guaranteed impact. And even though there's a place on every health region website and every regulator website on where to share your concern or your complaint, even though you start there, it's very confusing as you kind of wind your way through the system. Now, these stories, they get shared. It's just not with hospitals and regulators. And since we started up the Safespace project, we've collected nearly 5,000 engagements with folks who visited the app. And from those, we have thousands of stories. And these stories are shared, just not with people who are decision makers. Often we share these stories with confidants and social circles. We share them over social media sometimes. We go to patient advocacy organizations like the BC Friendship Centers, because there's a lack of a relationship and often a lack of trust between the system and us as people who experience harm. Harm is really built into the reporting system workflows. And when we were looking at building out the Safespace app, we really took a lot of time to see what were the general steps that could be shared across most systems. And we found two things. The first was that harm was extremely common in the healthcare system. The World Health Organization usually quotes, 1 in 10, 2 in 10, but it can be as high as 4 in 10 for people who visit healthcare encounters either in hospital settings or elsewhere. Indigenous peoples are often exposed to higher risk because of the effects of racialization. But when you report harm, you actually experience additional harm. And that harm can be from aggression from the system, retaliation from the providers that you're talking about, changes in the relationship, making it more hard for you to access services, people not giving you all the different options that you usually get. And as a result, anyone who reports healthcare harm, whether it's a patient or a provider or an ally, really shoulders the burden of change within our current system. And so the question that people ask isn't so much, is the change worth it? Because addressing any harm in health is worth it. The question they ask is it worth it to me? Can I take that harm? What will happen if these things happen? Now, if you continue moving through this workflow, you get to the point where you enter these confidential siloed investigations. This isn't any individual person's fault. This is just how the system is designed, and this is the sandboxes that we all have to live in. And if you are successful at having your harm both acknowledged and validated within that system, even though people get punished, that doesn't necessarily mean system change, because the environments that enabled people to think that this was okay still exist after the investigation is done. And these investigations often focus on individual incidences and people instead of patterns of care and cultures within organizations. So taking all of these things, we asked ourselves as we worked through building Safespace Networks, what exactly are we trying to do? And what Safespace Networks is it's a social infrastructure technology that accelerates organizational change in low trust environments using a learning paradigm. Now, I know that sounds really wordy, but what it more or less says is that when relationships are lacking, system change can't occur with the current ways we go about looking at change. So we asked ourselves, if we didn't have trust, if we had weak relationships, could we still achieve the same things? And so what we do is we partner with organizations that people already trust. BC Friendship Centers was an easy choice for us when we were looking at launching a network within British Columbia. Our system protects participants from retaliation. Our learning system collects anonymous data. We generate patterns. We validate those patterns through insiders. And then we move towards collaborative awareness. So if everyone knew that this was a problem, would that change behavior? If people knew that they were being looked at and saw these problems, they weren't blind to them, could that change behavior? And also helping patients to navigate systems as well. What we're trying to do is bridge the gap between centralized and distributed systems towards a new trust paradigm that you can then scale across a health system, where you don't depend on a single person to go and fix everything for you, like the Cheryl Wards of health regions, but you instead can have a scalable process. So what system transformation really is, and this is taken from a systems change presentation that I saw years ago. This is called the Kubler-Ross change curve. It's pretty well known. You start off with this initial stage where you have a status quo, something triggers a change. And as that change starts to go across the organization, you get people pushing back and denying that the change actually needs to occur. Now, if you get past the denial and get through the resistance that then builds, and the difference between denial and resistance is denial is kind of a knee-jerk reaction that I don't want to do this. Resistance is an organized reaction to pushing back against the change. Then you get into the stages at the end where you can get exploration and eventual commitment and get from A to B. And system transformation is really navigating systems, peoples, and beliefs towards a new way of doing things. And that new way of doing things has to shift resources. If there's no shifting of resources, then change doesn't occur. So unless you move money, people, time, physical resources, etc., you don't actually have change within a system. You just have a reframing of what's been done before. What we usually do in these cases is we organize committees to look at problems, we draft frameworks, we send out our consultative draft to different partners just to get some feedback. We then take that and we put together a report that we then send back to our partners again, and then we finalize it, and then we try and promote recommendations. And the challenge with this in the systems that we live in now is that this usually works in hierarchical systems where you can tell people below what to do. It doesn't work when you have people kind of moving around in multi-stakeholder environments who more or less aren't accountable to each other, which is really what we have in healthcare. So once again, going back to this curve, when you look at Safespace and what we do literally is we go through this process. So we look at internal and external stressors that spark change. This is a list of different ones. They can be fiscal, they can be social movements, it can be patient harm, evidence-based care, among other things. We then go through the question of what were the myths that come out from the data that we collect, and then what are the underlying biases that maintain the status quo within the systems that we're looking at. Examples within Indigenous health are things like things are just the way that they are. You know, we need more research before we can act. It will take generations to fix these problems. I mean, all of these things are really just beliefs. They aren't necessarily facts, and they're used in order to support the way that we still go about doing things. We then look at the workflow changes and the impacts, and this is really what underlies resistance within a system. If people have to work more, if things cost more, if there's an emotional weight that goes along with the change, we talk lots about how do I phrase this in a way that doesn't offend you. You know, that's really expressing an emotional weight that comes along with the change. Differences in who you report to, accountabilities, responsibilities, etc. You know, all of these things make up this formula for resistance. And when we're looking at system change within our framework, what we're really trying to do is take that operational impact and see its relationship to the change stressor that started all of it, the spark that initiated the change. So there's some big changes that got sparked in BC through people realizing that the drinking game that was published was not a one-off experience. It was something that was pretty widespread. And as people dialed up that change stressor, it then began to overcome those operational impacts and led to some of the changes that you're hearing about today. So if you can minimize the top part, those changes that happen in workflow, the way that people work day to day, and if you can maximize the change stressor, you have a much better chance of getting to that exploration phase. And when we look at how we organize and kind of work through our data, in general, this is one of the philosophies that we use and apply. So I'm going to turn it over to Kamea now for him to share some deeper technical parts of the Safespace Network and to talk a bit about the philosophy that underlies what we do.
Thank you. Can everybody hear me okay? Okay, fantastic. Thank you. So my role in Safespace is really to look at where the rubber hits the road. Unfortunately, when you have to design technology, you can't exist in the theoretical realm. You got to get your hands dirty and you got to start building something that people can tap, that people can use. And I wanted to just go over some of the fundamental principles that we're using to guide the development of the Safespace Network. And if I'm going too quickly or if people have questions, you're going to get a chance to dig a little deeper on this. But I just want to cover some really high level concepts that I think are critical in order to achieve some of the goals stated in these presentations today. And the first thing that I wanted to bring up was just this this idea of changing your mindset as you enter into the problem. The system is very large, it's very powerful, it's very slow moving. And sometimes you actually have to start tinkering on the edges and experiment with a new model that could potentially make the old one obsolete. And as you do that, as you change the way you think, you start to ask different questions. And one of my favorite things about technology is that because it's distributed and everybody has their own phone and everybody has their own computers, you tend to work more in the world of incentives. You know, how do you get people to do the natural behaviors that are in their best interests? And you start to get away from some of the old thinking, which is really just to create more legislation, more policy, more strategies, and doesn't directly attack the actual flow of the system itself. And so this is just an entry point. This is just how you start thinking about innovation in this space. My brother Alika reminded me of this quote. I'm sure many of you have seen this before, but culture eats strategy for breakfast. And when you're trying to create change, often it can feel like you're just putting sticks in the river. But those sticks in the river and all those programs and strategies and policies um, usually aren't strong enough to redirect the flow of the river itself. And so one of the key insights when jumping into solving some of these problems, you got to think and go beyond some of these system constraints in order to create a new approach. And that's what I'm going to be talking about with you today. So the first principle that I'll be talking about is this concept of immutable records. So some of you may have heard of the Wayback Machine, which is essentially a snapshot of all websites ever since the beginning of the internet. So you can go back in time and look at any previous version of a website. And there's a nonprofit that actually manages this. But this is a version of immutable records where you can't actually lie and say that your website said this when now we can just go back and look ourselves as an internet user. Bitcoin and blockchains are another example of this consensus layer of agreement where the transactions that occur on the Bitcoin network are public. Everybody can audit it. You don't have to trust some central organization that this is what happened. All of this is publicly available. You have other technologies like mesh network technologies where if communication goes down between one node, it'll just be picked up by another. And you can make sure that people can communicate without the internet. And the last one I wanted to touch on was just social media. And the reason I put an asterisk right next to this picture is because the nature of social media is starting to become regulated and become more centralized. Some of you may have been censored in the past for what you've said. And when you look at legislation that's being proposed, like Bill C-10, you start to realize the impact that authorities have on these decentralized systems as they start to regulate what can and can't be said on the internet. And just as one important point, because I know a lot of questions have come back to, well, what about the land? What's the context of how this affects the land? I want each of the Indigenous individuals on this call to just remember that the internet is just a wire that runs through your land across Canada. So the internet is literally an extension of the land. And I would caution you to not ignore how regulation will affect your ability to speak up on the internet and to get involved. Because when you look at Bill C-10, there were very few, if any, Indigenous people that were actually included in that policy discussion. So the individual who actually created this whole concept of distributed truth, or a wiki, many of you have used Wikipedia to get answers on the internet. There's something called Cunninghams Law, and it's kind of funny and a little bit ironic, but think it through and you'll very quickly realize why this is true. He states that the best way to get the right answer on the internet is not to ask a question, it's to post the wrong answer, and the swarm will come and fix it. I'm sure a lot of you have seen that as you've posted on LinkedIn or on Twitter, but this whole concept is incredibly important in this situation right here. So as you go through any of the CBC articles or any of the news media that's been published in regards to the remains found of those 215 children in BC, you'll consistently see the word records pop up throughout these articles. Why? It's because these missing children are undocumented deaths. Right now, there is a move to try and get the museums to fill in the gaps with their records. This is a massive ongoing problem with historical records, that many of them are actually being held with Catholic entities in the Vatican, and make it very hard to understand accurately what happened. And then it goes on to speculate that there may be reasons why they wouldn't want to actually record what happened in that residential school. And so we start to see why technology and immutable or uncensorable or unchangeable records is so critical to moving the narrative forward. And this all is thought about within the context of truth and trust. So in the past, when you had a problem, a patient would just go to the system to solve their problem. Now, with the rise of social media, every patient has found a new way to solve their problem, new incentives to change. And there's more options than ever to be heard, to share your story, to get justice, and to create change. And as leaders in the system, you're actually living through this monumental shift. And so the challenge is that as you go through this gradient of centralized controlled systems versus these distributed systems like social media, the challenge is that those on the left tend to have the resources to solve the problem, but they don't have the information of what to do. And those on the right, they actually have the information of what to do, but they don't have the resources to fix the problem. And so that's the reason we're in this situation right now, is it ultimately comes down to this lack of trust. And you can think of all sorts of ways that you could fix this. You can shift resources, you can change those resources and find better people. You can build bridges of trust. What we're proposing is actually something a little bit interesting, or when you think about this, is that's to actually create layers of communication where trust is less important. So how do you get the best of all of these systems? Because I just want to be clear that centralized systems aren't inherently bad. There are definitely places where it works better. A good example of where a centralized system tends to work better is public bathrooms, right? If you had a choice to go to a public bathroom downtown, any city in Canada, versus a private hotel bathroom, you could probably guess which one is likely to be cleaner. And that's because the incentives are different. When there's too much distribution of responsibility, you can sometimes fall into what's called the tragedy of the commons, where there's so many people that are responsible that nobody does anything. And then an example of where decentralized systems tend to work really well is actually in patient reporting. Because when you have an arbiter of truth in the middle who gets to decide what's right and what's wrong, it starts to, over time, create a lot of different problems. So the key to understand here is not that decentralization and centralization is bad or good, but to recognize and unbundle the parts of the system where centralization is clearly not working. This naturally leads into the next principle, which is called censorship resistance. Just as a reminder, I was talking about those immutable or unchangeable records. The reason why this is important is because of this. The monopoly of truth is upstream to the monopoly of violence. A state that can establish what is true is a state that can justify violence. And we have examples of this all across the world, that as long as they can get enough people to believe a certain thing, great atrocities can take place throughout history. If you just change this slightly, this also is true when talking about systems. A system that can establish what is true is a system that can also justify or become blind to the injustices that they've committed. So when you think about this problem, you have to think about this issue of where centralization versus decentralization fits, and what can happen if there's too much concentrated power or a monopoly on truth. So decentralized records end up becoming the ultimate check on every system. The next principle that I wanted to go over was this topic of sovereignty. It comes up quite often in these discussions. And the layer that I'm talking about right now is the layer of data sovereignty. So this implies the ownership, control, access, and possession of the data itself. And one of the personal issues I have with the way that it's currently defined is it doesn't actually go far enough. Because as you look at different setups for your technology approach, they tend to support different levels of sovereignty. So we're very used to authoritative organizations making choices on our behalf. But as you move towards a more internet experience, you start to realize that we're all starting to see the power of our individual rights. And so sovereignty needs to be dialed in all the way to the level of individual rights. And a lot of healthcare systems are trying to get there. But the key here is that data sovereignty is at the level of the individual and works optimally in a decentralized or distributed system. So as much as we might want to be the trusted party forever, I'm sorry to say, but there's going to be a cycle of trust. And whatever work you're doing now may not actually receive the same level of trust 10 years from now. And so you have to have a more dynamic system that allows for you to continue to tackle these difficult problems consistently over time. Now, because everything would be stored and publicly auditable, you start to introduce this issue around privacy. And there's lots of technologies that can actually help to ride the fine line between privacy and transparency. But I wanted to just define one thing for everyone who's on the call today, is this idea of a pseudonymous network or a pseudonymous economy. So pseudonymity is not anonymity. I think anonymity brings a lot of visually scary pictures into our heads, and I just want to clearly define this for you. It's a near anonymous state in which a user has a consistent identifier. Now, for any of you that have children who use the internet, I hope you're asking them to use a pseudonym when they play video games with their friends. It's not wise to put your personal information into these kinds of technologies. They get hacked every single day. It can lead to a lot of bad things. But what's great about pseudonymity over anonymity is it allows users to continuously communicate with one another in a generally anonymous way. So I'll just quickly define exactly how this could be used in the design of a system. So in the traditional system, you typically have to disclose your full identity as you enter the system. And what ends up happening has been stated on this call by many, there's reputational risk right off the bat. You have career risk, there's bias, discrimination, racism, there's straw man attacks and lateral violence that occur right as you start to report. And so what ends up happening is that individual enters the system and their complaint is dead on arrival. The systems are really, really good at eating the complaint and then digesting it and spitting it out. And often that individual gives up long before anything's transpired or any change has taken place. When you contrast it with some of the advantages of pseudonymity, walking in prior to entering the system, their identity is off the table. The biases are off the table. And now you can start focusing on what they've said. What is the assertion and challenging that specifically. You can start to collect evidence. You can use this as an early detection system. You can actually steel man the patient prior to sending them into the system. The reason why this is important is if you take a look at a lot of the sexual assault cases, the notable ones that have been reported in the news over the last 5 years, it always started with one woman. Then there was 2, then there was 30, and then there was 60. And as more and more women came forward, society collectively started to take it more and more seriously. And that's actually the power of allowing privacy to rule as a guiding principle when people come forward, so that their complaints, if they're valid, can actually receive escape velocity and get somewhere. And so they're now entering the system with a lot more education, a lot more support, feeling that they're not crazy because they can see that there's other people who have also had these problems. It opens up a variety of options. And for those that think that pseudonymous or anonymous systems are scary or this is dangerous, just know that they've been used for a long time. Back in the 70s, I worked with Crime Stoppers for the last 3 years. It was invented to protect people as they came forward with dangerous information. But this is the example of a pseudonymous system that I actually wanted to bring up, because this has actually been used since the 1920s to discuss international policy and have real frank and honest debate. And so Chatham House in London actually uses this to protect the, I like to call them the privileged and powerful, so that they can speak freely. And so as a principle, if you apply this to a healthcare system of reporting, you can actually use that same concept to empower the patients. And that the principles of privacy to protect truth tellers are just as critical as decentralization in designing a new model. Privacy is not only for those with power and privilege. And the last principle is challenging, but it's very, very important. And that is, as we talk about new words, new lexicons, new ways of describing the problem, we're going to eventually get the majority of people starting to clue into what we're saying. And we need to cross this chasm. And that's the same thing that every technology has to achieve, is jumping of this through this chasm from early adopters and innovators to the majority. This room represents a lot of innovators and early adopters, but unless we fully adopt these kinds of approaches in our technologies, we won't jump the chasm and get the mainstream population using it. So as just to wrap up the last principle here, to cross the chasm, innovation must be built from within the patient community that it actually aims to serve, and deliver value to every patient at every step. And that's how you cross the chasm, using technology approaches. And that's the end of my presentation, and I'll pass it back to Alika.
Alika,
To come,
yeah.
sorry, just to come full circle. When we were designing Safespace, these are really the principles that underlie the way that the technology is put together. And when we sat down with Leslie for the first time, she asked, well, how long would it take to roll out this type of system? And we told her, we'll have to give some time for the data to come out. We're going to have to test out some of these theories. We're going to have to localize it to the BC kind of contextual environment. And, 6 months in, we'll be able to re-release the next version, which will then unlock some of these features that we're talking about right now. And that's exactly where we are right now. So in the late part of June, early part of July, we'll be releasing with BC Friendship Centers a mapping system that uses a lot of these underlying principles in order to build out, these maps and patterns of patient care. I'm just going to spend a couple more minutes just talking about my own journey through the healthcare system and the reporting system, because I think sometimes people listen to us present and they say, well, you're a physician, you're a dentist, you've been working in tech, you're far removed from what went on. And you can look up on the internet a noose that was hung in the Grand Prairie Hospital back in 2016. And I was the one who actually reported that. And I remember coming out of my operating room and seeing it and thinking to myself, how could this happen? Why would someone do this? And I took it to the OR manager, and I told him, submit a report, put my name on it, and because this needs to be handled and done. And I remember going back to my OR, and I was on call that night, so I didn't get home till like 2 or 3 in the morning. And I woke up my wife, which I never do when I come home from call, and I sat her down in the office and I said, honey, I think I lost my job. And I went through the process of explaining everything, and I was crying to her because I was so afraid, because I know what happens to people who report these sorts of things. And at the end, I told her, I'm just really sorry. I couldn't live with myself if I didn't report this. And I'm not going to project onto this person like what they intended or other things, but that is the lived experience of someone who reports, especially something really significant. And so if you take me, an anesthesiologist, who sits on, national organizations, who lectures on racism. I've been in this area for 15 to 20 years. I'm the incoming CMA president-elect come fall. I am afraid when it comes to reporting this sort of thing. there's something seriously wrong with the system, because I can't imagine what it would feel like for another person to be put in my shoes and have to go through the same sort of thing. And so implementing safe space creates another way to share that can be in parallel to the existing system. We talk about uh, reworking the system. This is a way to create another way for people to report that lets the system and patients become aware of issues much, much earlier than happens right now. And it also enables people not to be forced into these workflows where, we fight each other and we're sitting on opposite sides of the table, when in reality, from our work that we've done with BC Friendship Centers, 80% of people who report just want the harm to stop. They don't want to litigate it in the system. They don't want to attack the person who did the harm. They just want it to stop. And so I strongly feel that there's a huge opportunity for us to continue the rollout of this program, to draw on champions like, Leslie and the BC Friendship Centers, and very open-minded individuals who are looking to make change within health systems, like, Cheryl Ward and Barry LaValle, Lisa Calder, who's going to speak in just a little bit. And, the presenters from earlier this morning who talked about their experience with nursing as a settler ally. There is so much space for us to make big change, but we have to change the way that we think about sharing truth. And we have to think about not focusing on personalities and individuals who are somehow going to shoulder the burden of change in changing the systems. We have to think of ways where we can do this in other ways. My final slide is just going to be sharing a campaign that was launched in partnership with the Downey Wenjack Foundation. I was a part of a group that wrote up this pledge and declaration, and it's really an action plan for the lost children who died in Canada's residential schools. The 215 children that were found near Kamloops Indian Residential School are not the only children who died in unmarked graves across the country. I've heard stories from my own family members who've attended residential school. I'm a grandson of, my grandparents both attended residential school. I heard these stories of places in and around the prairies, and we need to do something to make sure that these lost children are found and reunited with their families. And I just wanted to end on that note before handing it over to Dr. Calder. Thank you very much.